It's really important to say again that when you are doing these dressings, you have a very simple procedure in place to validate skill for the staff, and they do the same steps every time, but it's very important that they do all the steps and that they always make sure that they have good dry time in between every step. There is definitely a science behind doing a dressing change, so really knowing these steps is really important.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we are talking with MiKaela Olsen, Clinical Program Director in Oncology at the Johns Hopkins Hospital and Johns Hopkins Health System in Baltimore, Maryland, about the importance of properly changing central line dressings. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, MiKaela.
Thank you for having me.
So to start us off, can you briefly describe what central lines are and their importance in oncology care?
Our oncology patients often have to have a central line to get through their therapy. A central line is defined as a line that has been placed either percutaneously or is tunneled, and the tip of the catheter is in the superior vena cava, in the distal part of that, ideally at the superior vena cava right atrial juncture. In that location, we consider the line to be central because the flow of blood is very strong in that location, and we can administer vesicants and many other types of therapies that our patients need. So central lines are a really important part of many of our cancer treatment regimens. Some of them require a central line because there's continuous infusion of vesicants, and that requires a central line. Some patients just need a central line because their vasculature is challenging and it's becoming more difficult to place peripheral lines. Or we have a situation where somebody has a needle phobia and has frequent treatments, so a port or some other kind of a line central line can be helpful for those patients. But the most important thing with central lines is that we are very diligent about the care of these lines, and that's why we wanted to focus today on dressing changes.
I'm sure that our listeners, with a large group of listeners that are new nurses to oncology, they're going to experience a central line in their practice at some point, if not on a daily basis. Can you walk us through what the most important components of a central line dressing would be?
Sure. And you're absolutely right. I always say that to be an oncology nurse, you also have to have a subspecialty of vascular access. It is just synonymous to the care of our patients, and it is definitely a subspecialty. There are organizations that specialize in vascular access. We're lucky that ONS also has vascular access standards, but it's something that you have to study and kind of keep up with and understand to be able to stay up with the current evidence. So there's a big focus now across the country, as we all know, and has been on CLABSI prevention, which is a central line associated bloodstream infections. And we know that there are many ways to prevent central line associated bloodstream infections, which I'll now call CLABSIs. But one of the most important points at which a line can become infected is at the insertion site. So that central line dressing is of the utmost importance. We cannot ignore it, and we have to inspect it frequently and teach our patients to do the same so that we don't have an infection caused by bacteria getting into that insertion site. So the most important components of a central line dressing are the dressing itself, of course, and the antiseptic that we use under the dressing, the way we prep the skin around the dressing before we apply the dressing, and then, of course, all the technical parts of application of the dressing and making sure that it stays clean, dry, and intact. And this actually starts from insertion of the central line, because if we are not asking the people that insert the lines to ensure that they are clipping the hair before insertion and putting it in a place where it's a flat surface as much as possible, not in skin folds, not in precarious areas where it's difficult for us to keep a dressing on, then we'll have downstream problems. So I always say that the important parts of a central line dressing, actually the important components of doing a dressing, actually start from the insertion of that line in the first place. If it's up in the neck high by the ear and by lots of hair, we're going to just have continual problems. Those are some of the most important components of the central line dressing, and using a dressing change kit where the staff have everything they need in one location to do the dressing change is really important.
Thank you. So you just mentioned a dressing change kit. Can you talk to us about what would be included in one of those dressing change kits? I think that based off of where nurses might be working, so some nurses might be in large institutions that have kits available, but then there could be nurses that are working in a small office practice or some rural locations where they might not have kits. So they would need to pull all of those supplies together. So can you talk about what would be included in that, or what are the important pieces to include in changing a dressing?
What's interesting about that is, depending on the vendor and the supplier, oftentimes when you bundle things into a small kit, and there are a lot of different manufacturers out there that are making these now, you actually save money in some situations. So it's worth looking into. If that's not an option and it ends up that it's too costly to do a kit, then you can have a cart, and the cart can contain all the necessary supplies. We know that kits help make the procedure more redundant and help prompt the nurse regarding what supplies to use. But at a minimum, the components that are really necessary for doing a dressing change include the dressing itself, of course, the antiseptic that you're going to use. By the way, that should be chlorhexidine, which is the most superior antiseptic that we have available to us in the United States. It kills more organisms than anything else that we have available. If the patient has a chlorhexidine allergy, then you would need to bring in an iodine, a type of antiseptic. What we like to do first, if we're just using an iodine solution because they don't tolerate CHG, is to use some alcohol over the site first, and then to use the povidone iodine next. So the antiseptic needs to be in the kit. The next thing that needs to be in the kit is, well, I should have started with gloves, because I think it's really helpful to have your sterile gloves in the kit or in your cart right next to you. You also need a set of clean gloves to remove the old dressing. And then next need to have what we call the skin prep, or the barrier, the skin barrier. Some people call it a barrier. So after you cleanse the skin well with a scrubbing motion and allow that to dry completely, then you would apply the skin prep or the skin barrier around where the edges of the dressing are going to be. So not over the insertion site, but around the whole area where the dressing adhesive is going to lay. So you kind of paint that around where your dressing is going to lay. That also needs to dry completely. I think of that as like liquid Band-Aid, or a barrier between the patient's dressing adhesive and their skin, so that when you take that dressing off, it won't pull their skin off. And we know that pulling tape and dressings off frequently does damage and irritate the skin. The other thing it does is actually provides some adhesive component that allows the dressing to stick on longer. So the skin prep is really important in your kit or in your cart, and it shouldn't be something that you skip. Now, I will say, if you're working in a a clinic where you're just accessing an implanted port and you're going to de-access it same day within an hour or two of that patient's infusion, and they're going to go home without it, without the dressing on there. You're going to take that port needle out. There really isn't a need for a skin prep, and you can save a little money there. But if that port needle is going to stay in for something like a continuous infusion 5FU or something, you really need to make sure you don't miss that step. As I said before, it'll help your dressing stay on longer. It'll help protect that patient's skin. Next, you need your dressing. That's a very important part of your kit or your cart. After that, the dressing usually comes with securement pieces that you can use to secure the catheter tubing and put your date and time on there. Some institutions use a mask for the patient and the caregiver that's doing the dressing. And so if masks are required per your policy, then potentially those could be in your kit. And it's nice if you do a kit that you can stack everything in the exact order you're going to do the dressing change in so that it prompts you as you go through the steps.
Thank you. That was great. That was a really good point that you said about the kits could potentially be cost savings to folks. So that's a good thing to think about and to look into if it's not something that you already have in place.
Right. And I like the fact that when you get a kit, the manufacturer, the kit actually will basically open all the supplies for you so that it saves nursing time. Of course, the chlorhexidine has to be maintained and can't be opened, but the dressing and the other things can be opened in that sterile package, so it saves you time and less waste in the environment as well.
Really good points. So now that we've talked about what those supplies are, what are the risks if a nurse doesn't use one of those supplies that you just mentioned in their dressing change?
Most importantly, obviously, would be eclampsia, because if we don't get the dressing right and we don't do a good job with it, it's not going to be clean, dry, and intact. It's going to come off too soon. We really want our transparent, highly moisture permeable dressings that we put over our central line catheters to stay on, and the guidelines to stay on for 7 days. And then we need to do a dressing change. If they come off sooner and you're having to change them more frequently, then that can increase the risk of eclampsia. The second thing would be the skin integrity problems that can happen. And those can also lead to eclampsia, but they can be extremely uncomfortable and burdensome for patients if we don't have all the supplies and we skip steps like the skin prep, or we don't have the right dressing, or the adhesive bothers the skin. Then we're going to have skin damage, and that can lead to blistering, it can lead to weeping, and it can be very difficult to manage those patients. So I kind of pointed this out earlier, but it's really important to say again that when you are doing these dressings, you have a very simple procedure in place to validate skill for the staff, and they do the same steps every time. But it's very important that they do all the steps and that they always make sure that they have good dry time in between every step. Because the way I like to explain it is, first of all, if you miss a step, you're going to increase complications, decrease dressing longevity. If you don't let things dry in between the application of another solution or the dressing itself, then you're going to cause a chemical reaction or an increased risk of skin problems. So oftentimes when I get called because somebody has a really red, roaring skin and it looks bad under the dressing, the first thing I ask is, are we making sure we're letting these things dry appropriately before we stack them on top of each other? So be patient when you're doing your dressing and let things dry completely before you go to that next step.
Great. And that's such an important piece that you just mentioned about the drying and being patient, because I'm sure right now with staffing issues, things like that, it's just so important to remind nurses about all of those steps and how they really do need to take their time and the importance of that with their patients. So why is longevity an important focus when handling central line dressings?
This is one of my favorite topics right now, and there was actually a really good study that looked at dressing longevity, and they were able to demonstrate that The more you take that dressing off, which we call dressing disruption, the higher the rate of complications. And so there was a secondary analysis of a random multi-center trial where they looked at dressing disruption. And this was published in 2012. So it's an older study, but it really did very accurately describe the effects of frequent dressing changes, which is why I focused so much in the beginning on making sure that we do that dressing correctly and have a very strict procedure for how we do it. The number of dressing disruptions were related to the increased risk for colonization of the skin around the catheter at removal and the risk of major catheter-related infection and bloodstream infection increased by more than threefold after the second dressing disruption and by more than tenfold if the final dressing was disrupted. So again, we're trying to get to a 7-day dressing. We want to do everything we can at insertion and beyond to make sure that we do the dressings correctly for our central lines. That keeps that insertion site covered nicely so that bacteria can't get in there.
So now, MiKaela, let's talk about what can negatively affect the central line dressing's longevity.
The things that I already mentioned all can definitely affect the longevity of that dressing. But also, if the patient's having bleeding at the insertion site and we don't take care of that bleeding up front and we just change the dressing again and put a new dressing right over it, it's going to continue to re-bleed potentially. So there are agents that we can apply at the insertion site to help prevent that bleeding and sort of stop it up, if you will. And so that's very important. Other things that can affect the dressing longevity, if we don't clip the hair before we apply the new dressing, we don't shave the skin because that causes microabrasions, which can increase the risk of infection, but we clip the hair. And a lot of these manufacturers that make clippers will give you free clippers. Then you just buy the disposable sterile clipper heads, and then you can make sure that you prep that skin and clip the hair really good before you apply a new dressing. The other things that can affect the longevity include patient knowledge and making sure the patient is able to understand how to care for their dressing when they shower so they don't get it wet and have it falling off because of excessive movement or excessive torquing or stretching on the catheter lumens. So good patient teaching will help with this as well. Another thing that can negatively affect a central line dressing longevity is the patient's temperature. If they're having diaphoresis, if they're chilling and then febrile and then sweating, that can affect the dressing. So we need to really assess for and watch for these situations and help our patients. Putting lots of excessive tape over the dressing to get it to stick on is really not a good idea. There's actually good evidence out there showing that tape that is laying around in our areas, just sitting on counters and in drawers, usually are contaminated or colonized with some bacteria. And I was actually reading recently one study that showed 59 out of 80 of the tape specimens they looked at had pathogenic bacteria on them. So we really don't want to have a solution of just taping over our central line dressings to keep them on. We really want to apply everything correctly the first time, use that skin prep to help it adhere. And then if the dressing's coming off, then unfortunately we do need to change the dressing so that we can avoid the use of non-sterile tape over these dressings.
You've gone over so many important steps with these dressing changes, and I'm sure that some of our listeners are going to go back and listen to our discussion again, just because it's so important to keep all of those steps in place and to really watch for different things. It's the nurse's responsibility to ensure that dressing's longevity, and whether they're teaching their patients, they're going to be going home, and the things that the patients can also do to increase the longevity of that dressing change, or just the nurse being aware of what the importance is. So now let's talk through a little bit some of the challenges that nurses might encounter when changing a central line dressing, You mentioned bleeding earlier as one of the challenges that might come up that a nurse might have to figure out. So can you talk a little bit about those challenges and what strategies you recommend for the nurses to deal with them?
Bleeding is definitely a challenge, and sometimes it's related to the way the line was inserted. If they use a cutting mechanism at the site instead of using a dilation. So sometimes the root of the problem can be that you have to go back to the people that inserted the catheters and tell them about the downstream effects that they're causing and work on the technique. So we've done a little bit of that in my organization, and that can be helpful. But ultimately, we have cancer patients that are on blood thinners, or they're having other problems with their platelets, and they're just having oozing or bleeding around the catheter insertion site. And we know that any of that is really not acceptable, even a small amount of blood or dried blood, because that will increase the risk of bacteria growing at that insertion site and the risk of bloodstream infections. Back in the day, we used to just throw gauze over those sites to help with the bleeding. But the problem is gauze traps that warm blood under there as well, and even can dry and be very difficult to remove. So really, we've moved away from putting gauze under central line dressings and moving more toward some newer technology that we can use, such as a topical dressing that can form a seal and stop the flow of blood and exudates and protect the site from contamination. So there are some products on the market that can be used for prevention of bleeding. And it's important to note that the CHG impregnated dressings really say on their instructions that they are not to be used over bleeding sites. So you need to manage the bleeding primarily before you can apply these topical dressings to prevent CLABSI. So I would always advocate for a topical hemostatic dressing that can stop the bleeding rather than using gauze, because with the topical dressing, you can actually leave that dressing on for 7 days, and it can be really very effective. So that's probably one of the most important things. We did also talk about other challenges like showering and things like that that are really important.
Another challenge that a nurse might have is, you've got a patient who is experiencing diaphoresis. And when that happens, those dressings are so difficult to stay on. What could you tell a nurse who has a patient that is experiencing this and some approaches that they can use with changing that dressing?
It's definitely really challenging when you have someone that's really diaphoretic. The skin prep can definitely help. So that's important to apply the skin prep so that that dressing will stay on. And sometimes, despite our best efforts, when we have somebody that's very diaphoretic, we have to go to a stronger adhesive preparation. There are some on the market that are a little bit stronger to help that dressing stay on, even with the sweating. The last resort would be that we might have to go to a gauze type of dressing because they're just not staying on. That would need to be changed every 48 hours per our standards. So definitely challenging, but we do, in my organization, have what we call a difficult dressing SWAT team. And they're a group of vascular access specialists that really can go to the patient and help in these situations and provide some guidance to the frontline staff. So not something that is available everywhere, but something to think about if you have an organization where you might be able to have a resource like that to help out.
At the beginning, when you were talking about patients having the central lines placed and just the importance of what happens during that placement, you mentioned making sure that the hair is clipped in that area and that it might be on a flat surface. So it's not always easy for the surgeons who are putting those lines in place. We would love to have them all right in a very flat area where there's very little hair. And so it makes it easy for us. But let's talk about difficult insertion sites. What are some examples that you can give? And then with those examples, talk about how do nurses approach doing those dressing changes and just kind of maintaining them?
There's a lot of new information emerging about the insertion sites. And we know from not new information that the site with the most infection is, of course, going to be in your groin area. And the next high risk site is going to be in the internal jugular area in the neck. And then the best site, we think, according to the literature, is in the subclavian area down lower below the clavicle, which is a nice flat area. Now, the problem and the reason people inserting these central lines are kind of avoiding sometimes the subclavian site is because that's closer to a lung and they worry that they could cause a pneumothorax during the insertion. A lot of times people will just choose the IJ site, and we have terrible problems keeping those dressings intact, especially with beards. And we have a lot of difficulty with the tubing and the lines pulling on that site. They perceive that as safer because the lung is farther away. So what we need to encourage and what is evidence-based now is the use of ultrasound during insertion. With the use of ultrasound, then not only can we place lines with less complications and less risk of pneumothorax, but we can place lines in a more optimal location like the subclavian vein. So hopefully we will do less blind insertions of lines and we will move lines down to more optimal sites. We also need to think when we're placing these lines about staying away from things like a tracheostomy where there's lots of secretions or another wound that the patient might have, and thinking about using PICC lines in patients that have chest wounds or trachs, because the PICC line, which is the peripherally inserted central line, would be in the arm down lower away from those sources of potential infection. The last thing that we want in many situations would be to put a line in the groin. But sometimes our patients have tumor all in their upper body. They have other reasons where thrombus or whatever that precludes them from getting a line up in the upper body. And we have to go lower. But what we're trying to do is we're trying to encourage providers when they place them in the femoral vein to come down from the groin area down onto the upper leg so that we can avoid those moist folds of the groin that are so close to the perineum. And that's a really important strategy that we're trying to teach. So those are not things nurses can do, but nurses might in their area work with providers and help them understand how the way they insert the line and the location is so important to prevention of CLABSI. It basically advocates or helps with dressing longevity. What the nurse can do, though, is to have all those tools I talked about earlier, the skin prep and the clippers and the antiseptic solution and any other tools that might help that dressing stay on longer, even if it has to be dressed in a more precarious situation or place on the patient's body. All of those strategies I talked about will help it stay on longer. There's also something called anchoring devices. So if your patient's in a hospital that have adhesive on them that you can stick to the patient's skin, and then you can put the tube, the catheter or the tubes of the IV tubing in those anchoring devices to help prevent pulling, because anytime your tubing and your lumens pull, they're going to pull that dressing.
Okay, great. Thank you. So, MiKaela, we're coming to the end of our time. It's been a pleasure talking with you today, and you can just really hear how passionate you are about this topic and the importance of this that our listeners really need to know and understand. So as we are finishing up, there are a few questions that I always end our podcast with, and I'm going to ask those to you now. And the first one I have for you is, what are common misconceptions about central line dressings?
I think that there's just a misconception that you can just keep reinforcing it or stack more dressings on top of it. I always say that you can do a whole hour-long teaching session about the anatomy of a dressing change and how to do it properly. If you stack dressings on top of your transparent dressing, it can no longer breathe. And now it is going to trap moisture under there and cause infection. How you apply each of these chemicals, the dry time, there is definitely a science behind doing a dressing change. So really knowing these steps is really important so that we can save our own nursing time and save our patient's skin from all the dressing removals. If we're not doing these dressings as much, we're all going to be happier, the patient and us, of course, and we'll prevent CLABSI.
Next question. What's something about central line dressings that's not often discussed, but you wish people knew more about?
As nurses, we're so used to doing dressings and all kinds of procedures that we just grab the dressing and just stick it on. But I know from experience teaching so many people how to do dressing changes that we really need to look at the manufacturer's guidelines and we need to see how they recommend you apply and remove the dressing. There are very specific techniques about doing both of those two things that definitely affect how well that dressing is going to perform. So for example, when you remove a dressing, the companies will usually tell you to remove it slow and low, because if you pull it off rapidly or you pull it high, you're going to pull off that top layer of the patient's skin. And then each time you do a dressing change, the skin gets more and more damaged. The other thing that they will say in their manufacturer guidelines, and I encourage you, find out what dressing you use, go on the company website, download their posters, get them to come in and do education, because these little details really matter and should be included in your training and education. When they tell you what to apply the dressing, there's also a very thoughtful approach to how you use the warmth of your gloved hand to help the dressing adhere during the application. And that is also important for the longevity of that dressing.
What additional training or education do oncology nurses need on central line dressings?
I would say just everything that we talked about today, all of the tips, all of the steps, I would ensure that that's in a skill validation checklist. And not only are the steps there, but the rationale, because when nurses understand the why behind each of these items, they really get it. And then they understand how important it is to take the time to do it correctly and not rush through it. I would encourage the why to always be in that training and education.
And then lastly, are there any additional resources for both patients and providers who want to learn more?
Definitely looking at the resources that the manufacturers for our dressings and antiseptic solutions and skin preps, looking at those resources. They have a lot of great things on their websites that can help guide nurses. I think that's the first thing that comes to mind. And then for our patients, we really need to make sure that we have good patient education materials, because if they're going to go home with this line and be responsible for watching it and caring for it and calling us when the dressing is loose or not adhering completely, or there's bleeding at the site, then we need to make sure that they and their caregiver understand the importance of that and who to call for help.
Excellent. Well, MiKaela, thank you so much for joining me today and for this really important topic for our listeners. Do you have any final comments for us?
Just have fun really getting familiar with proper dressing changes, and hopefully all of these tips will help you to prevent CLABSI in your organization.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.